Welcome, everybody. Thank you very much for joining us today. And welcome to our American Thoracic Society Thoracic Oncology Assembly webinar entitled Current Controversies in Pleural Disease Management. I'm Roger Kim, the chair of the ATS-TOA Early Career Professionals Working Group and assistant professor of medicine at the University of Pennsylvania. And I'm joined by Milind Bhagat, assistant professor of medicine at the University of Minnesota. And together we'll be moderating today's discussion. Before we get started, we just wanted to remind everyone that this live event will be recorded and uploaded to our Assembly website afterward. If you have any questions throughout the webinar, please place them in the chat and we'll try to address as many as we can at the end of our time together. As a reminder, the views expressed during this webinar are those of the speakers alone and not necessarily endorsed by the ATS or the BTS. With that being said, I'm very excited to introduce our pleural disease expert panelists today who will be sharing their insights with us. They truly represent some of the world's leaders in the field, and we are honored that they have agreed to participate in this webinar. We are, full disclosure, still waiting for one of our panelists to join, Dr. Rahman, who is the co-chair of the British Thoracic Society Pleural Disease Guidelines Group. Oh, and I see he just joined, so perfect timing. Naj is also the director of the Oxford Respiratory Trials Unit and the professor of medicine of respiratory medicine at the University of Oxford. Welcome, Dr. Rahman.
Thank you. Sorry, folks, had some Zoom issues, but we're all good now. Hi, everyone.
Next, we have Dr. David Feller-Kopman. He's the section chief of pulmonary and critical care medicine and professor of medicine at the Dartmouth Geisel School of Medicine. Thanks for joining us today, Dr. Feller-Kopman.
Thank you.
And last but not least, we have Dr. Abhinav Agrawal, the director of interventional pulmonology and bronchoscopy and assistant professor of medicine and cardiovascular and thoracic surgery at the Zucker School of Medicine at Hofstra Northwell. Thanks for being here today, Dr. Agrawal.
Thank you for having me.
Before we dive into our discussion topics, Milind will provide a high-level overview of some of the salient points from the recently updated British Thoracic Society Pleural Disease Guidelines. Take it away, Milind.
All right. Thank you, Roger. Thank you to all the panelists for agreeing to be here and all of you joining us online. So just to provide you with some context in which we are going to have this discussion are these new BTS guidelines for pleural disease and clinical statement on pleural procedures, which came out last year. Now, the guidelines are only about 60 to 70 pages long, and I have a full 3 minutes to go over this. So I'll just be giving you a brief overview of the topics we are going to be discussing in the 3 main sections of the guidelines. So first up here is pneumothorax. As you can see from the old guidelines on the left side, size of the pneumothorax along with the symptom of breathlessness was an important factor in deciding when to intervene. With the new guidelines on the right side, whether the patient is symptomatic or not, and then the patient's own preferences now take precedence in the algorithm. Regarding management options, right here at the bottom, due to multiple clinical trial evidence in the interim, there's been greater detail in those boxes of conservative care as well as options in managing with ambulatory device. Going on to the next slide with the pleural infection section of the guidelines. As you can see in the newer guidelines, which are the color coordinated sections in the middle and the right side, there's been a newer algorithm concerned only with the diagnosis, risk stratification, and eventual decision-making of inserting an intercostal drain. And then on the management part, you can see the insertion of the rapid score there in the newer guideline, probably for prognostication than management decisions. There is obviously an introduction of TPA plus DNAs in the newer guidelines, which was not present in the old ones, and now they stand right beside the surgical management. The newer guidelines in the bottom right also give us specific options if all the above therapies fail, something to consider. And the last and the third part here is the malignant pleural effusion pathway. The most obvious part here in the management section is the ascension of an indwelling pleural catheter as a management option for both non-expandable and expandable lungs. For the lung that is considered to be expandable, the guidelines now place IPC with or without talc pleurodesis right alongside early pleurodiscus strategy with an inpatient admission at the same level of evidence. So yeah, this was the overview. With this, I'll hand it back to you, Roger, to initiate our discussion.
Thanks so much, Milind. So at this point, we're going to transition into going through a couple discussion questions that we've come up with to sort of hit on these three main topics that Milind just gave a great overview for. So to start us off, since the 2010 BTS, British Thoracic Society Pleural Disease Guidelines were published, as Milind mentioned, several high-profile randomized controlled trials have been published in journals like the New England Journal of Medicine and Lancet, to name a few, that have suggested that conservative and ambulatory management for spontaneous pneumothorax may be safe and even considered regardless of pneumothorax size in select patients. Thus, one major change in the updated guidelines is that pneumothorax size is no longer an absolute indication for invasive management with a chest tube. So the question for our panelists is, in your clinical practice, how does pneumothorax size factor into your decision-making, if at all, for pneumothorax management at this point? And for this question, we'll start off with our BTS representative, Dr. Rahman.
Wow, so I need to be careful what I say if I'm representing the whole BTS, but good. Thank you so much, Roger. How does pneumothorax size factor into my management? The answer is very little indeed, except to say that the pneumothorax needs to be of sufficient size to consider intervention, and it's a decision point then. I'm just going to pull back from that slightly. We're obviously talking about primary pneumothorax here in general. I think all of you will have experience of patients with small pneumothoraces by any criteria, ACCP, BTS, whatever you like, even the Belgian, less than a centimeter, less than whatever, who are significantly compromised because their lung function is so poor to start with, and even a little bit of pressure in there causes a problem. So, of course, we encourage people to treat the patient always, not the X-ray. And I've seen 4 or 5 millimeter pneumothoraces cause major compromise, as you guys would have done as well. And in that case, you need a strategy. But for the primary pneumothorax, do I care how big the pneumothorax is? No. One thing I think, if I may, Roger, just to develop it slightly further. So, okay, let's leave size to the side, large or small, doesn't matter so much. It matters about symptoms. I'm not sure we've done a great job in the guideline on thinking about trajectory of symptoms, not just presenting symptoms. And I think that's pretty key. So when I'm teaching my fellows, I would say, look, if somebody had ripping chest pain 2 weeks ago and has been fine since, then if they've got a complete pneumothorax, well, so what? That's probably just going to sit there and do nothing. If somebody had ripping chest pain 45 minutes ago, you need to work out what their trajectory is. And if they've got a complete pneumothorax now, then they may be the very small number that tension. Sorry for a complex answer on behalf of BTS.
Any of our other panelists have anything to add regarding the size question for spontaneous primary pneumothorax management?
Sure. I, of course, agree with Naj. He says it so eloquently. I think that the key points that I'd like to clarify, and I'd love his insight on this, is number one, defining is the patient symptomatic. And I agree in full to treat the patient and not the X-ray. In terms of symptoms, I would sort of quantify that in terms, or qualify that in terms of chest pain versus dyspnea. And chest pain, I think, is certainly manageable. But if you're ambulating someone around the ED and they're dyspneic, I think that is probably the more important symptom that we focus on instead of pain. I have often sent patients home with the conservative management algorithm with pain control as long as they're not too dyspneic. The other thing that I'd love to discuss is the true meaning of primary spontaneous pneumothorax, and I think we might be getting to that a little bit later. But I wouldn't so much make the distinction in terms of primary versus secondary, but comorbidities. And there are patients who may have a primary, what's considered a primary pneumothorax, meaning no known underlying lung disease, but for example, who have severe aortic stenosis and may not be able to tolerate pneumothorax in an ambulatory/conservative management. And then the final point on size is we don't really know a lot about iatrogenic. So as someone who does a lot of pulmonary procedures, we cause pneumothorax not infrequently with our lung biopsies. And as I've gotten a little more gray hair, lost a little bit more hair, I've been a lot more conservative in my management of iatrogenic.
Abhi?
It's hard to follow Naj and David, on the topic of pneumothorax, but I agree. I mean, I want to highlight David's point, two points that he picked. One, I mean, the dyspnea on exertion, right? So when you have a patient, and of course, I mean, we have to take the caveat of where the patient is being triaged, right? Because sometimes we don't get to make that decision by the time we see that patient, especially in an acute setting. But, size in our management has, fallen by the wayside by itself. And, comorbidities matter a lot. So when you're taking size into account, the trend matters, the trend of symptoms, as well as sometimes the trend of imaging, right? I mean, there's rapidly expanding pneumothorax that's getting worse and the patient is getting progressively symptomatic. That does matter. And then, primary spontaneous pneumothorax, if anything, is easier to deal with. But those secondary spontaneous pneumothoraces with, patients who have interstitial lung disease or, COPD or significant cardiac comorbidities, that's where sometimes we may be a little more aggressive. But it's a pattern change that we have seen in our practice, and we are again more conservative and focus more on the symptoms rather than the size alone.
So, Roger, can I just come back in on a couple of points, if you don't mind? So David and Abhi, both of them raised really good points. So concerning pain, I mean, I agree, breathlessness, if somebody's breathless, you need to do something. That's fairly straightforward, I think. The pain thing is tricky because obviously we have analgesia, which one can escalate. And I think you need to take a clinical judgment here. So look, if my fellows send somebody home on high-dose morphine, I'm going to be pretty cross about that because I think, a little bit of paracetamol or whatever the generic is, okay, maybe. And we should be clear of the integrity of the data. And the Brown paper had patients in whom they included only patients who had very low pain scores at baseline. We've got to be clear about that. So if you've got somebody screaming in pain in A&E and you think, I'm going to open up my analgesic cabinet, I don't think that's following the data. I think they weren't included in the conservative study. That's my first point. The second point that I think David's raised very eloquently is about the physiology. I know that David's a man that loves physiology, and quite rightly so. We tried, I think, in BTS to get away from primary, secondary. We talked about high-risk characteristics, and we clearly couldn't name them all because we can't encounter every situation. So a beautiful one was given, somebody with a big aortic gradient. Absolutely, you would treat them as high risk because they can't afford, in inverted commas, to drop their lungs. So I think engaged brain is my big bit of advice, probably.
All right, so I'm going to go to the next question. The conservative management you mentioned, Dr. Rahman, of spontaneous pneumothorax may manifest differently in real-world clinical practice compared to how it was executed in the clinical trial setting. In the study by Dr. Brown and colleagues, you mentioned patients in the conservative management arm were observed for at least 4 hours before a chest X-ray was repeated and room-where ambulatory testing was performed. In routine clinical practice, to successfully implement this approach requires obviously interdisciplinary collaboration, patient buy-in, and a careful assessment of all the risk factors involved. How have the panelists here integrated a conservative management approach for spontaneous pneumothorax management into their respective health systems, if at all? We'll start with you, Dr. Feller-Kopman.
Yeah, so that's a great question. And I think one of the key underlying points for conservative management strategy is to have the infrastructure to safely manage these patients. So patients need to be in proximity to a healthcare facility should things go wrong. Since moving up here to rural New Hampshire 3 years ago, we have patients traveling 2 hours for a clinic visit. So that's tough. And I don't necessarily trust a lot of the local hospitals because if they do present with a pneumothorax, even if I put in the X-ray order for a follow-up for a clinically stable pneumothorax. When they see the pneumothorax, they freak and put a chest tube in. So I think you need the infrastructure. Ideally, you have a nurse or an advanced practice provider as part of your team to help ensure adequate follow-up and the clinical resources. The other interesting thing for conservative management is what happens, I think, a lot more outside of the US, which is needle aspiration. And there's good data for needle aspiration for pneumothorax. It's just that in my institutions, I always think the incremental invasiveness of a 8 French pneumothorax catheter or arrow thoracentesis kit versus the 12 or 14 French pigtail is a millimeter. So there's really not a lot of difference between that. I'd be very interested to hear what Abby and Naj say.
Dr. Agrawal.
Yeah, of course.
Your unique experience.
So, I mean, I had the experience of transitioning from a center that did not do any conservative management to, where we have increased the frequency. And so to what David mentioned, education and collaboration with the interdisciplinary team becomes extremely important. But more important is setting up that outpatient practice, right? So living in a busy New York area, you can end up at a different hospital and somebody will put a catheter in you, at the drop of a hat. And so triaging and, setting up that outpatient programs becomes important. But also to what Naj mentioned, I mean, we need to look at, David mentioned, we need to look at data carefully, right? So, I mean, when we talk about needle aspiration, there is increased risk of subsequent pleural procedures. When we talk about conservative management, we talk about the complications rate are lesser. So in terms of distinguishing primary, secondary, and iatrogenic, I think this becomes important here. We feel for iatrogenic patients, we are more aggressive in terms of being conservative, rather. We feel comfortable if they're not expanding. For our primary spontaneous patients, again, the same thing. But for our patients that do have comorbidities, we want to make sure that that follow-up is set up pretty well, because we want to make sure that they are seen in clinic the next day. We do that ambulatory management. We walk them in the ER, and sometimes with the workflow in a busy tertiary hospital, that can become challenging. So we have faced those challenges in our, true transmission from data to clinical practice, at least in our hospital.
And Dr. Rahman, you probably have a unique perspective, especially for our American practitioners on this, on kind of lessons learned for a successful, like a conservative management program, what to do and what to look out for.
Sure, thanks. I mean, I agree with what Abby and David have said, absolutely. I mean, the way I think about this is much the way that we thought about indwelling pleural catheters in 2005-06, right? So the mistake most people made was thinking that the difficult bit was inserting them. Actually, that's really very straightforward. The difficult bit is when the patient calls you in 6 weeks and says, well, there's some fibrin in the tube and I'm living 2 hours away and I've got chest pain. So it is about thinking about the patient perspective of what it's like to have this done. And remember, the conservative deal with the patient is we're not going to do anything because it will get better on its own, but that means we still have to look after them until it gets better. And I think that's also forgotten. If you look at the Brown paper, I think 20% in the conservative arm needed a pleural intervention. Now, it was 99.5% in the intervention arm, obviously. So it's better than the intervention arm, but it's not zero. And that means what? It means if you treat my father, well, no, my father wouldn't have primary. If you treat my brother with a primary spontaneous pneumothorax, I would fully expect him to have a phone number. I'd expect him to have an escalation policy. I'd expect him to not just turn up to the local A&E and go, this guy didn't treat me. Now, what do you want to do? Because that's not conservative management. That is, I don't want to treat you. They're very different things. So I'm quite strong on that side of things. We may come to it later in this discussion, but this is particularly applicable to the ambulatory care. If you're sending them home with a device, you need escalation policy. And then I think you referred to this very well, Milind, in your question, which is the cross-disciplinarity of it. So I think your relationship with emergency medicine as pulmonary internal medicine, who is going to take responsibility for the treatment or the not treatment, and then the follow-up, that's absolutely key. I would map it on your indwelling pleural catheter practice.
Thank you all for sharing these incredible insights. I want to kind of pick up on a theme that has already started to develop, which is how do we define the difference between a primary and a secondary spontaneous pneumothorax. So notably, the BTS guidelines actually even from 2010 and continued in the update to define a secondary spontaneous pneumothorax to include, of course, folks with pre-existing lung disease, but as defined by the guidelines as anyone older than 50 years of age and with a smoking history. So that's a pretty broad definition of folks that would potentially qualify as having a secondary spontaneous pneumothorax. And, just from my anecdotal experiences and, just chatting with folks kind of socially, I'm not sure if that is a practice guide definition that is necessarily used in routine clinical practice. And I'm very, very curious to kind of hear how all of our panelists in their own practice define a secondary spontaneous pneumothorax. And for this question, we'll start with you, Dr. Agrawal.
Of course. So, I mean, Naj, I think very eloquently pointed it out, right? The guidelines are moving away from differentiating between primary and secondary for that specific reason. And it brings us back to the question of why do we need to distinguish primary and secondary, right? So the question is, the primary pneumothorax are patients that have a high preponderance of having a pneumothorax without significant comorbidities, and therefore are more likely to be able to tolerate conservative management or being able to tolerate the pneumothorax and then coming on to the recurrence risk in those patients versus patients who have secondary spontaneous pneumothorax, so defined by the guidelines, are those who, when they have an event, are more likely to have significant adverse events related to the pneumothorax itself, as well as a recurrence of pneumothorax, and that recurrence, guide us to doing a more definitive intervention in those patients. And so, for the audience, what I want to clarify is that it's not about just having two separate words of primary and secondary, but rather trying to distinguish which are the patients that would upfront, or at least at the first or second event, require a more definitive intervention, both when they present to you as well as to prevent a recurrence, versus those who could be managed conservatively because they have a stronger, pulmonary or cardiopulmonary reserve, and would have, if they're not in a high-risk profession, would have a lower risk of recurrence. And even if they do have a recurrence, they could tolerate that. So I want to distinguish that rather than, and you can look at, the upcoming guidelines that the CCP is working on and the BTS guidelines, where we are moving away a little bit from just, blanket descriptions of primary versus secondary and moving more towards spontaneous pneumothorax and how to manage them in the presence of comorbidities.
Dr. Feller-Kopman or Dr. Rahman?
Yes, I agree in full with Abhi. I would refer listeners to a nice piece by Bincliffe published in Lancet Respiratory Medicine, I think it was 2015, talking about, is it time to rethink categorization of this? Because there was early data from Mark Nopin's group where he was thinking about the concept of pleural porosity. A lot of these patients with classically defined primary spontaneous pneumothorax had actually emphysematous-like changes and increased pleural porosity that were distinct from plebs or other areas that you might think were the source of the pneumothorax. So a lot of the initial definitions of primary versus secondary were really in the pre-CT era, in the as sort of when thoracoscopy went getting the. So I think almost everybody probably has some sort of underlying lung disease. You just necessarily haven't seen it grossly. And I agree with trying to use other factors to predict risk recurrence in our management algorithms.
Dr. Rahman?
So thanks. I mean, I completely agree with what Abhi and then David have said. I think the why question is critically important in decision making. What's the point of distinguishing? And the point is you treat them differently. Now let's just take that to the next level. Why do we treat them differently? Because the outcome is different and the recurrence rate is different and the mortality is different. So the mortality of primary spontaneous pneumothorax is several zeros less than 0.1%. Thank goodness. It's like 1 in 100,000 or nearly 1 in a million, actually. The old data would suggest that the mortality of secondary spontaneous pneumothorax is in the region of 10 to 15% per admission. I really want to know that difference, because the idea of sending home somebody with a 15% mortality and say, well, just see how you get on and give me a ring is probably not brilliant medicine. So that's certainly one area. let's just reverse engineer that and say, do primary spontaneous pneumothorax patients have normal lungs? I think it's very clear that they do not. Having said that, do they behave the same over the medium to long term? No, they don't. And actually, a male PSP patient has a recurrence rate of approximately 24% over 5 years. A male secondary spontaneous pneumothorax has a 40% recurrence rate, or 45%. So the big phase epidemiology, I'd point you out the paper by Rob Halifax in JAMA a couple of years, about 4 years ago, and that was over 100,000 pneumothoraces in the UK health system. There is absolutely a double peak, one in the early 20s and then one in the mid 50s, and they behave differently. So I think it does make a degree of sense to say, what category are they in? I don't like the term secondary because it implies that primary is clean and secondary, we know the lung disease. I think high risk is probably the better way to do it, but we should definitely work towards saying which category are they in. And my own view, and I'd be really interested in David and Avi on this, I very rarely manage what I think is a secondary high risk conservatively. The least I would do for them is to observe them in hospital. The idea of me sending them home and saying, give us a ring if you're a bit breathless, I won't do that myself, but be interested in views.
I could chime in on that. I mean, I agree, the secondary spontaneous, and, to answer that question, Roger, earlier is, we do use imaging routinely to assess that risk factors. Whatever the underlying lung disease is. So that tends to be our distinguishing factor versus, the classic primary spontaneous pneumothorax, that young male patient that will present to you. But we do not send patients home with secondary spontaneous pneumothorax. We will pursue sometimes in ambulatory management in those patients, but not from the conservative management standpoint. We would watch them in the hospital because of the higher risk of decompensation, as Najib eloquently pointed out from Rob's paper, that the mortality is higher, the recurrence rate is higher, the readmission rates are higher, and so it would make sense. But we do tend to use imaging if there was a factor. But going back to what I was talking about is, it is important to understand the reason for distinguishing is the management, and so the comorbidities and high risk, I think, is a better word rather than secondary spontaneous pneumothorax, because those are the patients that would both require early intervention as well as more likely a more definitive intervention in the future.
Dr. Feller-Kopman, any additional insights to share?
No, I think that was very well said.
All right, then we'll move on to the second section, which is the pleural infection section. So among non-frankly purulent pleural effusions, the guidelines, which I mentioned before, emphasize the importance of initial pleural fluid pH testing to categorize the risk of pleural infection and with the LDH, and subsequently guide the decision to whether to place a chest tube for drainage or not. However, to ensure accurate pH measurements, we know the samples should be technically placed on ice, analyzed within 1 hour. This, just from personal experience, is not always possible in all different clinical practice settings. So what is your particular approach to risk stratifying all these potentially infected pleural spaces, and how do you decide when a chest tube is indicated? And we'll go first with you, Dr. Rahman, because again, with this, you'll have probably a different kind of setting experience as well.
Sure, thanks. So what's my approach? I think in the BTS 2023, we've given a kind of a traffic light system, so it's not so black and white. pH 7.2, less than 7.2 bad, pH greater than 7.2 good. Actually, if you reflect on the fact that we still have less than 7.2 is clear-cut, complicated, and should be drained, and greater than 7.4 is likely uncomplicated and reassess and don't drain. What we've created is a middle category, so that's going to drive more drain insertion, not less. And that's accepting that a pleural pH, even in John Hefner's meta-analysis, as great as the data was not 100% sensitive, so that's one thing. And then secondly, it kind of accepts your very nice point, which is pH is one of the worst measured things in clinical medicine because it's so vulnerable to change, and we proved that in possibly the most boring paper ever published, which when we stuck pleural fluid into a gas analyzer by deliberately contaminating it, and showed that even retaining a little gas of a bubble of gas would alter the pH, and we all know about lidocaine and so on. So I think we have to recognize that pH is not always reliable unless you kind of do it yourself live. if that's the case, my advice to people watching is to look at the glucose. The glucose is very robust to measurement. It's very difficult to change the glucose even with a cat-handed technique. And so if the pH and the glucose are not together, I would generally trust the glucose, not the pH. And then I would go and look at the LDH, which is why we've got this more feathered approach. The other area to think about is we need to treat not one test, but A, the patient, and then B, the totality of the data. And so, for example, septated pleural fluid is probably more associated with complicated paraneumonic effusion. And we know that septation can alter pleural pH measurement. So if you've got somebody who's swinging a fever, they've got good going pneumonia, their CRP is 400, and they've got septated effusion, if that pH is 7.4, I will disbelieve it and just put a drain in. That's my practice. And then finally, CT as well. There are some features there, the split pleurosign, pleural enhancement. Remember that there's a differential for that, including rheumatoid and malignancy. But again, if you've got other persuasive data, I don't think we use the pH as either the umbrella or the license to do or not do something. So I think we need to take all these things into account.
Dr. Agrawal or Dr. Feller-Kopman, any thoughts?
I could talk about, it's interesting because when I came here at Northwell, we have 2 tertiary centers, and one would run a pH immediately and the other one would send it out and I would get it back the next day. And so, it was the conundrum that I faced that most people face. And, even before the BTS guidelines, it is very clear that you do have ancillary tests. And I think the most important thing is the patient, having a fever, do they have a white count, or the CRP high? What is your pretest probability of infection? And if it is high in the setting of, especially having a septated effusion, but even if it's not, and your glucose comes back lower, your LDH comes back, 900 or 1000, you would go ahead and put an intercostal drain. And so that is what our practice has been, is not relying on the pH by itself. Of course, if it is available, it is very helpful information with the caveats, as Naj mentioned, of rheumatoid arthritis, of malignant effusion. But I mean, erring on the side of caution in the right clinical setting, we do tend to proceed with intercostal drains if the patient has the clinical signs and symptoms of infected pleural space, and then reassessing that. So I've had that experience, and so I think glucose, but the BTS guidelines does use that traffic light system very well, and now does help you even if you don't have that pH. What other factors you can use, such as glucose or LDH, to guide that decision making. So that's a very important point, and it's in the discussion section. It's very well highlighted.
Yeah, so this is perhaps one of 2 criticisms I have in an outstanding document. And Naj and I have talked about this. I was on the BTS discussions regarding this. I personally wish that they would have put ultrasound as the initial decision point. And the reason for that is patient presentations are sometimes very difficult in pleural infection. Of course, we'll see the textbook patient who presents with fever, cough, sputum with a pneumonia and an effusion and chest pain. Those patients very likely have a complicated pleural space or empyema. But we also see patients who look totally fine without symptoms. They have some anorexia, some weight loss, failure to thrive. And putting the ultrasound high in the algorithm, if you see a hyperechoic effusion, if you see some septations, that's very likely going to be a complicated space. It also saves me from sticking the patient twice. One, even though it's a 25 gauge Lato needle, to sample the fluid, then you have to have the blood gas analyzer on the unit. You wait, you're sitting there. I personally don't have the time to do that. I know the NHS they have the luxury of hanging around all day, but in a busy practice, that's tough to do. And then I'll go back to the incremental invasiveness of a thoracentesis versus the small bore 14 French or less pigtail is very little. So if I ultrasound the patient and it's a hyperechoic effusion or septated, I'll probably lean towards pigtail. If it's a anechoic effusion in the same clinical setting, I might start with the thoracentesis, but I'll also try to drain out all the fluid. And if I drain out all the fluid and it still comes back with poor prognostic signs, high LDH, low glucose, but there's no fluid, that's a patient that I don't have to put a tube in right away. I'll just repeat an ultrasound and see if the fluid's coming back. If the fluid's coming back, they get a tube.
This is incredible. I feel like these are some of the things that we struggle with on a daily basis here at Penn, at least. I'd like to
Roger,
move yeah, please.
can I just I'm going to come back to David on that. I respect that opinion. Yeah, exactly. I respect that opinion completely. And actually, there's a lot of sense in prioritizing the ultrasound. In real life, it's the first thing we do, right? We don't get the pH first, we get the ultrasound first. I guess there's two things to say just as a counterbalance. I'm not disagreeing or not disagreeing much. You can tell that I'm a Brit, right? I'm not an American, don't disagree violently. There's two things. One is, has there ever been a study which has used ultrasound triage to diagnose pleural infection? There has not.
That's what we need to do.
I agree with you, David, 100%. But we should be clear that there have been pH studies that have done that, but there haven't been ultrasound studies, and there is a differential for septated diffusion. So by and large, in the right context, yes, but malignancy and all sorts of things can septate. And then secondly, in terms of the large volume thoracentesis, I really agree. And in fact, within the current guideline, it suggests that even if your pH is okay, but there's a large effusion and you're suspicious, you should just go ahead and drain that anyway. So I guess I'm kind of agreeing and disagreeing at the same time. Sorry to come in, Roger.
No, this is great.
Abhi, yeah. So I mean, to Naj's point, I mean, I agree, Naj, what you're saying is, with the catheter itself. But coming back to, if the ultrasound is showing a septated diffusion, despite infection or not, I mean, there may be a role of putting an intercostal drain anyway in that patient in the right clinical setting in a symptomatic patient, both from the diagnostic standpoint, but as a therapeutic standpoint. And if the ultrasound, yes, the study has not been done, but we do know that ultrasound is, pretty good at predicting exudative effusions, even if it is not good at, there are no studies yet, to David and Naj's point of predicting, infection. There may be a role of using that ultrasound to put a catheter in, both from the diagnostic and therapeutic standpoint, to prevent subsequent procedures in a busy setting. And so we do, if we see a septated diffusion up front that has the right clinical characteristics in clinical practice, proceed with intercostal drain, 12 French or a 14 French, instead of, doing a diagnostic thoracentesis and then proceeding in that select clinical scenario, yes.
And if I may, the other thing that I would add, as we await the results of MIST-3, which is the RCT of conservative management versus intercostal drain versus early surgery, doing the ultrasound first, if you have a really good operative candidate and a good minimally invasive surgeon, it may be that you don't even put a tube in, you call your surgeon and they definitively manage that space. We await those data then.
So actually, that brings us perfectly to our next discussion point, which is precisely this question of, all right, so now that we've kind of established that there's almost certainly an infected pleural space, but now we're actually worried that it's a complicated pleural infection. Currently, the BTS guideline recommends a small bore chest tube, 14 French or smaller, as many of our panelists have already alluded to, and fibrinolytic therapy up front, rather than any of the alternative approaches, which, for example, could include medical thoracoscopy or surgical drainage with VATS or thoracotomy up front, as Dr. Feller-Kopman just alluded to. Just to name a few kind of studies related to this topic, for example, compared to chest tube placement and fibrinolytic therapy, a 2020 randomized control trial, albeit small, by Dr. Kyer and colleagues, documented that initial medical thoracoscopy is both safe and may shorten hospital length of stay. And then separately, a 2022 multi-center retrospective cohort study demonstrated that initial surgical intervention was actually associated with reduced treatment failure, again, with all the limitations of it being not a randomized clinical trial. And then, of course, most importantly, as Dr. Feller-Kopman just alluded to, the recently published initial results from the MIST-3 pilot trial results that confirm that upfront fibrinolytic therapy has really become the de facto standard of care in routine practice in this patient population. And of course, the follow-up phase 3 trial, larger phase 3 trial, which will directly compare initial fibrinolytic therapy with surgical management for pleural infection, we all eagerly await. However, in the current absence of definitive high-quality evidence in this space right now, I'm very curious to hear all of our panelists' approach to this really complicated clinical question. And I think for this one, we are up to Dr. Feller-Kopman to get us started off.
Thanks, Roger. It's, as you mentioned, a sort of data-free zone. We have good data that Surgery can be avoided with the use of TPA DNase. One of the caveats, though, that I've felt over many years is that surgery in and of itself should not necessarily be an endpoint. I think thoracotomy should be an endpoint that we want to avoid, but a minimally invasive 1 or 2 port mini BATS has a small incremental invasiveness over chest tube management. So I think the most important thing is to have a multidisciplinary approach to these patients. These are complex patients who can get sick and have a very high morbidity and mortality. So this is an area where we want to work with our surgeons. Many surgeons, purely anecdotally, like operating after a dose or 2 of TPA DNase. They say the surgery is a whole lot easier. And I really look forward to those data coming out. But I think it depends on both your patient. Are they a decent operative candidate, or are they, obese, diabetic with renal failure? And also your surgeon. Are they good at minimally invasive pleural intervention? As I'm sure Najib would love to point out, the surgical data is based on I think one study, one small RCT of 20 patients in the streptokinase era. So we really need the results from this drug.
Abhi?
Yeah, of course. I mean, so I think it's, when we talk about this question, I think it's important to step back and, you brought up a few points, all right? So I think there's the question of the role of intrapleural fibrinolytic therapy, comparing that with, video-assisted thoracoscopic surgery. The question of, I think, medical thoracoscopy, which I think is very nascent to actually give any true judgment based upon the current data that we have. And then the thoracotomy, right? So, I mean, I think it's important, and I think, in the paper that Udit first authored with DFK and Najib were part of, we tried to delineate this, and AHAB does this well in the STS guidelines as well, where it's important to identify the stage of empyema. Are you in the exudative phase? Are you in the fibrinous phase, right? Because if you're in the exudative phase, that's where it's more likely that intrapleural fibrinolytic therapy or intercostal drainage will work. Versus if you're in the phase where a pleural rind has developed, those patients may benefit from earlier surgical intervention. But again, it's also important that we clinically follow these patients closely, right? So there do not have to be days between making a decision of IPFT and then surgery, meaning that they should not be either or. If you put a pigtail catheter in and then there is no drainage, we talked about this at our conference in AABIP. We want to, in the first 1 or 2 hours, make that decision to putting intrapleural fibrinolytic, and then in the next 24 to 48 hours, assess for drainage and see if the patient is non-draining or it's a non-draining effusion. Consider surgery, because we do know that the patients that will end up going to surgery, the longer we wait, there is an incremental increased incidence of requiring thoracotomy in those patients, right? There's clinical direct correlation. But it's also important to understand from the the medical thoracoscopy standpoint, we have to look at what the outcomes are. So just looking at the MIS3 data, it was an initial feasibility study, and if you look at the randomized, both the groups, the time to discharge was similar, but that study was not powered enough, as Najib pointed out more eloquently, to look at a difference in readmission, even though at 2 months they did not show any difference in readmissions or any further interventions. And similarly, if you look at the medical thoracoscopy studies, there was a difference of 1 day in length of stay in those studies. And so it's important that we have parameters that are more patient-centric that we establish before considering, medical thoracoscopy as an upfront approach, based upon evidence. Najib.
Thanks, Avi and David. Look, there's a lot to digest here, isn't there? There's lots of issues, and I agree. Let's just break it down a little bit. I've noticed that Ihab Badawi is on the call, actually, and he authored the MIS3 study, so he knows a great deal about this. Let's just talk about MIS3 for a second. MIS3 was feasibility. I think what we showed in MIS3 is that you can randomize patients to a surgical versus a non-surgical trial, and that was the big outcome. Fascinatingly, we showed the same length of hospital stay, 7 days, with intrapleural treatment and surgery. But in the NHS, patients took 3 days to get to surgery. Now, what that tells me is if you can operate on patients quickly, to David's point, you can probably get them home really, really fast indeed. But no one's ever done that study. So that's point number 1. Point number 2 is, I think, of course, I did MIS2 and I'm very pleased with it, but it couldn't answer every question for everybody. And how could it? Only 50 patients had TPA DNase. It showed that it has biological plausibility and it shifts clinical outcomes, which is amazing. But could we then answer these feathered questions of immediately or after a day or plus or minus surgery and all this jazz? So I think we're learning iteratively as we do these studies. And then my third major point before I talk about the case study is I think case series should be dismissed. It's very, very clear from mesothelioma research, from pleural infection research, that if you let people choose too quickly, they choose patients who probably didn't need an operation, do an operation, and they do brilliantly. So I think we have to be very careful about case series. Let me just directly handle, Roger, the issue about medical thoracoscopy. So there are 2 large case series from Europe, both of them very flawed by selection bias. Both of them claim 92% success rate with thoracoscopy, but when you scratch the surface, almost 50% of their patients needed a further intervention beyond medical thoracoscopy. So that's hardly successful. The CURSE study has, I think it was a brave study to do, a good study to do. A, it's tiny, and B, it's got a major methodological flaw, which is they counted time in hospital from the time of the intervention, not from the time of randomization, and that has bias in it. You should always, as you guys will know, you should count time from randomization because that's when your groups are equal. And so if I randomize you to medical thoracoscopy and I wait 10 days, but I only start the clock ticking at 10 days, your disease has changed. And unfortunately, that study, that was their primary outcome. If you look at the secondary outcome, which was time from randomization, there's no difference at all. So I don't buy that thoracoscopy has any advantage over TPA DNAs, I'm afraid. And I think we need a bigger study. The final question then is about how we've constructed the guideline. Given the balance of all those things, what we have said is put a tube in and then assess them early. So in 2010, rather shamefully, we said assess them at 7 days. Now we're saying assess them at 48 hours, which is something much faster. Could you make the argument that should be after 12 hours? Yeah, you could make that argument. And in fact, in EHAB's study in MIS3, we put a tube in and watched them for 24 hours. Doing that, 15%, 1.5, had complete drainage of their pleural space. So there's definitely a rationale for waiting a little bit before you start to do X, Y, or Z. Now, to David's very elegant point, should it be surgery? Should it be TPA days? We don't know. And I'm happy to announce to this group that we've just been funded to do the MIS4 study, which will be a definitive, we think, 670 patient study of surgery versus TPA DNAs as initial treatment. So that's a question that has not yet been answered. And I agree with David. I don't think surgery is a bad outcome. I think we've worked hard on what those outcomes should be. If people want to think about some American centers, I'd be delighted to discuss that.
That's great news, Dr. Rahman. We'll be eagerly looking forward to those results. So just for the sake of time, we'll move on to the next section, the malignant pleural effusion section. So in pleural effusion cases in which secondary pleural malignancy is suspected and would confirm evidence of metastatic disease, cytology is recommended as an initial diagnostic test. However, in the age of targeted therapies for non-small cell lung cancer and molecular testing to guide anti-cancer therapy, pleural fluid cytology samples are often inadequate. Thus, an alternative reasonable approach seems to be upfront thoracoscopy or pleural biopsy to expedite the diagnostic process. So what is your current approach to malignant pleural effusion diagnosis right now? I will start with you as well, Doctor.
Sorry, with me, Milind, or with?
Yes. I think it's you. Yep.
I didn't hear. I'm so sorry. Yeah, okay. So Milind, I think let me just very quickly summarize where we are with the data. I think as pulmonologists, we need to move on from cancer positive, cancer negative, because that's just not our job anymore, is it? It used to be when I started training, when we were pretty pleased to say non-small cell, small cell, but the world has changed. And our job, I think our job is to make our patients feel better and give them enough information to get definitive oncological treatment. That's at least at the early diagnostic. And we now know quite a lot about this space. I think the cytology positivities altering with different cancers is very well known now. Meso 10%, adenocarcinoma lung 70%, breast 80%, fine. Actually, that's not the interesting question anymore. It is how often do you get molecular markers out of the initial pleural aspiration? And we have data on this, both from my unit and from Kevin Blythe's unit in Glasgow. Just to give you one piece of interesting information, the cytology positivity for ovarian cancer is about 85%. Sounds brilliant. the odds ratio of having inadequate molecular markers is 80 times higher than other cancers. So that immediately tells you how useless aspiration is. So we feel happy, we've got the diagnosis, and it's never enough. Within the study that Rachel Mercer did in our group, that was nearly 1,000 cases, we looked at how often was the first aspiration sufficient to get definitive oncological treatment in MPE, and the answer is 32%. So this is not a great test. Now, to answer your question directly, Milind, is it now justified to go straight to biopsy? We don't quite yet have that data. Let me give you a scheme which I hope will be shot down by David and Avi because it's not based on anything except my prejudice. So what we do locally is if they are high risk of having mesothelioma, so asbestos exposed and a positive CT, malignant looking CT, the likelihood of that patient getting sufficient data from an aspiration is less than 10%. And in those patients, if they're not too symptomatic, I'll take them straight to a thoracoscopy. That's okay. I think in the middle group, where they are perhaps likely to have squamous cell or hematological malignancy, a cytology positive rate of less than 50%, it's not unreasonable to think about straight to a biopsy. But if their ultrasound shows nodularity, I would do a biopsy and an aspiration in the same setting. Of course, you need the skill to do that, but that's what I would do. Now, having said all of that, like a broken record, I will say we are currently doing a randomized trial on this, and we are looking at doing two things actually, which is direct to biopsy plus an IPC upfront in likely malignant diffusion. We're actually asking two questions there. One is, can we get a quicker diagnosis and moleculars? But the other is it better for the symptomatic journey? Imagine breathless aspiration back again, and then definitive pleural intervention. How about definitive pleural intervention right up front? So one of my colleagues, Dinesh Adala, is doing that as a feasibility study called Streamline. And so honestly, what do I do locally? I put them in the Streamline study, but that doesn't really help your audience.
All right, Dr. Feller-Kopman, do you agree?
Yeah, it's a really great open question. We do not know the answer for this. I love Najib's approach, and this is something that we do, which is if there's nodularity on chest wall with ultrasound, at that time we will do a needle biopsy and then proceed with drainage. One of the big factors that we're working on here is every institution has their own hurdles. But our hospitalist group keeps sending patients to the interventional radiologist for repeat thoracentesis. And it's sort of like steering an ocean liner. It's taking some time, but we actually have some data now that we're going to present to the hospitalist. So again, I think it's just an important way to work with your team. And that could be thoracic surgery, interventional radiology, hospital medicine. I think that it depends on your likelihood of mesothelioma, but if you have a relatively low incidence of mesothelioma and a patient's presenting with their first pleural effusion, it's not unreasonable to start with a thoracentesis. I do think it's unreasonable to do 3 or 4 thoracentesis. So after the first lymphocytic exudate, I'll recommend a biopsy, usually visualized, and also IPC at the same time.
Yeah, I mean, I agree with Naj and David. I mean, I think it's important. I mean, we're not very good at predicting, or we're not very accurate at predicting exudative effusions, right? So the question is, what is your pretest probability first off if it's a malignant diffusion? And then based upon that, what is your pretest probability of what kind of malignancy is underlying, right? So if your question is mesothelioma, I think a thoracoscopy upfront makes sense because we know that one cytology is extremely poor. So I think there's value to assessing if you have a high pretest probability of a malignant diffusion. And then if you have a high pretest probability of a malignant diffusion that has underlying malignancy or a high suspicion of something which, as Naj mentioned, is in that 20 to 40% range, less than 50% squamous cell hematologic malignancies, upfront thoracoscopy may not be unreasonable. But I think there's value to doing a thoracentesis as well, not just from the diagnostic, but from the symptomatic standpoint, right, for some of these patients. So I think that's where the decision comes into play. We talk to the patients. I think the problem with randomizing anything in terms of thoracoscopy versus a thoracentesis is that the problem is, are they malignant or not? And so the number of patients that actually don't have an underlying malignancy that would get excluded, something that me and Udit have been talking about, of trying to randomize patients upfront straight to thoracoscopy versus thoracentesis. And we know that the cytologic yield is okay, but the yield for molecular markers is not great. Despite Kamaran's paper that was published recently with cell-free DNA, we do know that for definitive yield, it is not good. And so what our approach is, to summarize that, is if you have something that if you have a high suspicion of malignancy, and if you have a low pretest probability of something that has low cytologic yield, then we are more aggressive in discussing thoracoscopy upfront with a definitive management that may include rapid pleurodesis, something which we may discuss later. Or if we have a pretest probability of something like a lung adenocarcinoma, then we will consider at least a diagnostic thoracentesis, both to assess relief of symptoms, lung expandability, and Naj can comment on that in terms of how accurate that is, as well as see if we get a cytologic marker and molecular markers from that fluid itself. So not a very well data-based answer, but we await data from Naj's group and hopefully some of our data here.
So just to throw that up, Abhi, and I know I'm going to mention the word manometry because David's on as well. I think the whole other area is trap lung and what should the definitive intervention look like. And so I think I'm not dismissing therapeutic thoracentesis. It's important to show that your patient gets better. That's important. It's important to understand what the radiology looks like afterwards. That's also important. I mean, you might, if I'm being cheeky, you could make the argument, well, just put an IPC in, and then if the lung expands, put some talc in through the IPC. So you can kind of feather this any way you like, but let's answer one question at a time, I suspect. Yep.
Well, unfortunately, we are at the hour. This went by so quickly for, I know, Milind and me, and I suspect for all of our attendees as well. I just wanted to thank all of our expert panelists for spending an hour of their time with us today, especially Naj over in the UK, being so late at night over there. I really do appreciate all of you guys spending the time to share your insights. And I personally got a lot out of this and learned a whole bunch, and I know Melinda too. And I know that everyone's going to be listening live and also on the recording are just going to learn so much. So thank you so much again for attending.
Thank you, everyone.
Thanks.
Have a good day.
Thank you all.